So, as I was telling, roughly only 1 to 3% of the obstetric patients need critical care, but this has to be perfect. Otherwise, we're going to lose either the mother or the baby. Now, we also should know that two-thirds of the patients who are going to land up in an ICU would never have been anticipated at the time of their conception. That means problems like, let's say, a heart disease or a liver disease would have been definitely ruled out by the time this patient, comes at the conception or initial visits. So, what we are going to deal with mostly will be obstetric problems in this two-thirds of the patients. Now, we also know that the pregnant and the postpartum patients pose challenges in terms of altered physiology. So that means our critical care, our support that we are giving to that patient, the drugs that we are giving to that patient, the dose of the drugs, the duration of its action, everything changes during pregnancy, and we have to be sure about what we are giving. Fetal monitoring and maintaining a fetal-friendly environment is very important. Unfortunately, majority of the ICUs to maintain a fetal-friendly environment is extremely difficult. Now, pregnant patients who are in ICU are more prone for hospital-acquired infections. That is because the ICU invariably carry a lot of germs, different kinds, including resistant bacteria in their atmosphere. And there is a good possibility that our patients who are immunosuppressed can get infected. So this is one of the reasons for coming up of HTU where there is not multi-organ failure. We should be able to manage the patient in the HTU, or even the concept of obstetric ICU has started off in a big way where including ventilation and dialysis are done on the obstetric floor. Next one, please. Now, this is just to show that when you have a patient in the ICU, there are various kinds of things you may suddenly see, and you see a whole lot of drips going on with a lot of different vasopressors, maybe double support, maybe triple support, and so on. The patient may require plasmapheresis, patient may require dialysis, or once in a way, as you can see in this the last one, where there is blood in the tube or in the ventilator tube, which indicates that this patient has gone in for a pulmonary edema. So these kind of pictures we have to get used to if we are going to work in a critical care setting. Next one, please. I'll quickly go through 2 or 3 cases so that we know what kind of things we are handling in an ICU. Now, this is the story of a 29-year-old primary gravida with no significant history, referred to me with post-vaginal delivery with severe PPH following inversion of the uterus. She was admitted for induction of labor at term. She was induced with cervical gel. Patient had a vaginal delivery with RMLE of a live male baby of 2.8 kgs in 24 hours. Post-placental expulsion, inversion of the uterus was noted in that nursing home, followed by PPH. The placenta, mind you, had not separated. The uterus was repositioned and vagina and the uterus packed. 3 units of PRBC and 1 unit of FFP and 3 Emaxer were transfused, and then the patient was transferred to our maternal fetal medicine unit. Next slide, please. On examination, she was in shock. GCS was hardly 2. The peripheral pulses were extremely feeble. 180 beats per minute was the pulse rate. 94% was the SpO2 on room air. She was very pale. She had a packed cell, oxytocin, and dopamine drip on flow. Now remember, this patient was suspected to have inversion, has got placenta in situ, and they are giving oxytocin. If you give oxytocin to these kind of patients, the constriction ring that is formed at the cervix will become more and more tight, and it will almost become impossible to reposition the uterus by mechanical means. The BP was 90/60 at that particular time with the dopamine on flow. The Foley's catheter was in place, but there was no urine in the tube. Uterus was 14 to 16 week size, firm with dimpling at the fundus. On local examination, there was a pack in situ with fresh bleeding through the pack. And of course, episiotomy wound was very edematous, showing that a lot of circus has been done at that end before the patient was shifted to us. And this is the scan picture which we did in that place, showing the, you can see the inversion of the uterus very well. You can see the Foley's bulb in front, and behind that is the inversion. The fundus is down. The next slide, please. No, I think you missed one slide. Parma, no, ugly, huh? Okay, 1 minute to proceed. Okay, now patient was shifted to ICU and ventilated. More blood and blood products are arranged. Inotropic support was stepped up from 1, we went on to 2. Patient had cardiac arrest within half an hour of reaching the hospital. She was revived. I tried mechanical repositioning and wanted to post her for a Haltanes because that was the only thing that was left at that particular stage. But before that, the patient had recurrent episodes of cardiac arrest and patient could not be revived and she was declared dead 2 hours after admission. Next slide, please. Now, the next patient that was referred was a 29-year-old P2L2A2 referred for tertiary care post LSCS with eclampsia, health syndrome, ARF, and pulmonary edema. Next slide, please. So these are the various scan pictures to show that there was a grade 1 nephropathy, there was a gallbladder wall edema, interloop ascites was noted, uterus was subinvoluted, and there was pulmonary edema on a X-ray chest. Next slide, please. Okay, and this is just to show the ABG. We'll be going a little bit more into the ABG because the obstetrician should know the basics of ABG. You can see that the pH in this particular case was 7.292 and the PO2 was only 37. So it showed that she was not too good. Next slide, please. Now, I had to do a plasmapheresis of 3 cycles, then a dialysis of 5 cycles because she was in ARF. Multiple transfusion was given. Fortunately for her and fortunately for me, the patient recovered and she was discharged on day 10. Next slide, please. Now, another example was a 23-year-old primary gravida. She was referred in shock as amniotic fluid embolism, BIC, and PPH. Next slide, please. Now, this patient has a very funny history. She went for a routine checkup and was told to be in labor, was admitted in a hospital in Anantapur. Now, mind you, Anantapur is roughly about 4 hours away from Bangalore by road. It's in Andhra Pradesh. Augmentation of labor was done with oxytocin at 11:40 a.m. She received injection Brotin and Epidocin every half an hour. I was reminded of this case when Dr. Piley was talking about the hyperstimulation and Brotin and Epidocin. In my labor room, Brotin and Epidocin have been banned for the last almost 10 years. We'd never allow that ambulance to come into the labor room. Patient had 2 episodes of vomiting, following which the patient developed swelling of the whole body and face. Pulse was feeble, there was the tachycardia and BP was not recordable. In that place, she received the multidisciplinary care, anti-shock treatment was given, steroids, inotropes. Patient was stabilized, but by that time the baby had died. So the relatives were told that now the baby is dead inside, the patient is reasonably stable, and we are going to go ahead with the further induction. Next slide, please. So it was augmented and a forceps-assisted vaginal delivery was conducted. A male stillborn baby of 3.5 kg was delivered. Now, following this delivery, patient had 1 episode of vomiting followed by unconsciousness after half an hour. The uterus was relaxed with bouts of fresh bleeding. Patient's condition deteriorated. Transfusion and inotropes were started. HB was only 4 grams and she was referred to me with unrecordable BP and a feeble pulse, of course, along with an anesthesiologist. And I had told them that 4 hours is too far for you to shift, but they said, sir, she's going to die here. You try whatever you want over there. We are going to shift her. And so she landed up with me at 2 a.m. in the middle of the night. When she came to me, she was cynosed, pallor was 3+, her heart rate was 150, BP was not recordable, uterus was 24 week size contracted, and the PV pack was fully soaked and episiotomy was gaping. At that particular time, when we did the ABG, it was 7.3, but within a short time after that, the ABG became 7.244, the pH. The next slide, please. So this is how she was. She was immediately put on ventilator. The next slide, please. Fortunately, with all the care that we gave, the patient recovered. And within 2 years, she came back to me for another delivery. Of course, I didn't want to take any chance. I did a C-section on her. And about 3 months back, she came to me for a second baby. And this time I told her, lady, no more pregnancies for you, and did a tubectomy. Next slide. So there are certain facts that we need to reiterate when we are looking after a critical care patient. Any pregnancy, mind you, any pregnancy can develop life-threatening complications at any time with or without any warning. Now, I'm repeating this again, and I showed you all only postpartum cases so that it goes into the mind that 63 to 92% of all admissions are postpartum. Now, we are a little bit lucky in obstetrics. The intensive monitoring is much more required than the life-saving interventions in our patient population. And the median length of stay in the ICU is only 2 days. Quite often, the patient is very, very sick. You feel she's going to die at any minute. And next day morning, you come, the patient is so well stabilized that she's sitting and asking for food. Now, mortality rate differs significantly between high and low income countries. In high income countries, 3.3% of all patients admitted to ICU die. In third world countries, it is as high as 14%. Now, why is this happening? Because we are not, as obstetricians, we are not used to critical care of the patients. So each one of us will have to do some amount of critical care to ensure that our mothers go home alive. Now, also apart from the fact that most of the public health facilities in India do not have a special care unit for high-risk pregnancies and postpartum mothers with complications. All of them are being managed in labor room without a dedicated team of competent providers and appropriately equipped facilities. So the lesson to learn is that every hospital should have a maternal fetal medicine unit headed by either a maternal fetal medicine specialist, since they are a very rare commodity, at least an obstetrician who is interested in high-risk pregnancies. You cannot be doing a laparoscopic hysterectomy and then coming and looking at a high-risk pregnancy. That's no way possible. You need to concentrate on what you're doing and go ahead and do it. Next slide, please. Parma, next one, please. Okay. Now, we next go to some of the important aspects before we go actually into the ICU. How do we move a pregnant patient to the ICU? Now, high level of care when the patient is clinically unstable. What do you mean by clinically unstable? She could be hypertensive or she could be hypoxemic, or she could have a high risk of deterioration. That is increased work of breathing. Unfortunately, we obstetricians are very, very poor in monitoring the pulse rate, in monitoring the respiratory rate, the type of respiration, and checking the heart. These are the four major mistakes we do. And unfortunately, because now we have got a fetal Doppler, in olden days, we had to have a stethoscope around our neck all the time, at least to check the fetal heart. So automatically we would check the mother also. But now most of our youngsters are moving around only with a pocket Doppler, and everyone has forgotten the art of using a stethoscope. Please remember, a stethoscope is indispensable in the field of obstetrics. We need to have it. Okay, so if the patient is breathing very heavily, axillary muscles are playing, her respiratory rate is more than 20, 25, 26, 28, she may have a normal BP, but mind you, this patient is going to lead you to trouble. Be careful about her. So monitor her respiration, monitor her pulse. Or if you're doing a laboratory work, your laboratory work will give you some clues. Like you can do an arterial blood gas or a serum lactate measurement. Now, if these are abnormal, it identifies a woman with progressive clinical deterioration, and you need to shift her to ICU. Don't keep her in your labor room. Now, most patients with hypertension and major obstetric hemorrhage, again, I remind you, we are lucky in obstetrics because our patients are young, our patients are healthy. They require only level 2 care. That is monitoring and simple intervention, rather than level 3 care, which is a major organ support. Now, I showed you an example of most of the cases of level 3 support, because the level 2 support is much more simpler. If you can handle a level 3 patient, to handle a level 2 patient is very easy. Next slide, please. Now, we should know that there are two types of ICU models. You must see where you're working and what kind of an ICU model you have in your hospital or in the hospital that you're going to refer your patient to. The two types of models are open and closed units. Now, what's an open unit? An open ICU is one where an obstetrician can admit their patient under their name, and the admitting doctor maintains responsibility for the management of the patient. For example, my ICU is an open ICU. So when I admit the patient, the patient is admitted under my name. I take the decision of which multidisciplinary team to be involved, And if anything happens to the patient, I am solely answerable to the patient. But the advantage of doing it is no one, mind you, no one understands a pregnant woman and her fetus more than an obstetrician. So the obstetrician should have the art of critical care if you are looking after high-risk patients. Now, the closed unit is one where you can shift your patient, but you are no longer in control of your patient. The ICU team takes over the responsibility of the patient, and the members of the multidisciplinary specialty, including the obstetrician, are consulted when necessary. That means you are at the mercy of an intensivist. Rather than you employing the services of intensivist, the intensivist employs your service. There's a big difference between the two, because obstetrics is something where things change minute to minute, hour to hour, and obstetrician has to be there available all the time. Okay, then we go to the triage of critical care. Now, as obstetricians, we have got 3 to 4 only important places with us. One is, of course, our operation theater. The most important is our labor room. Then if you have an HDU, then you have an obstetric HDU, or you could have an obstetric ICU. Now, from each of these places, you either step up, let's say from labor room to HDU, or from HDU to ICU. That's called stepping up. You're giving a better care to the patient, or more sophisticated care to the patient. Or if the patient is stable, you step down. From ICU, you get the patient down to HDU. She is much more stable. Then you put her in the wards. Or you can discharge them from any of these setups, provided they're quite stable. Now, any patient or admission within 24 hours, supposing it's at 2 o'clock and the senior obstetrician doesn't want to come at 2, I don't think that could be taken as an excuse. If you're doing an obstetrics, you know that you've gone into obstetrics for giving 24/7 service. Okay, so with a complication or adverse event should be adjected to mortality predictive scoring using GCCSS. We'll go a little bit into detail after this. Thereafter, you do an organ dysfunction score, or the ODS, according to which disease or which organ system is involved. In the event of utilization of both the scoring system, a clear picture of disease severity and the maternal fetal prognosis will be revealed, which you can use to counsel your patients and manage and plan your management further. Next slide, please. Now, before we go a little further, what are the common indications for admission to ICU? You can have either obstetric indications, or you have a non-obstetric indication in a pregnant patient. Now, in the obstetric patient, we all know eclampsia, HELP, AFNL, hemorrhage, or sepsis are the common indications. Of course, as you can see in that MRI picture, what I put up, there is a placenta previa accreta. In my hospital, we deal with a lot of accreta syndromes. They're all, of course, referred. And we do a uterine artery embolization followed by the surgery. And I'm able to save quite a few uteruses before, really landing up with hysterectomy. Of course, massive transfusion is a must. You cannot avoid that. The non-obstetric indications will be cardiac or respiratory, renal, neuro, gastrointestinal, or diabetic ketoacidosis, a trauma, or a thromboembolism. So these factors, based on all these factors, we decide, okay, now this patient is going to go into ICU. Next slide, please. Okay, now, so we have seen the triaging in the ward. Now, the process of shifting from a ward into a triage room to ICU. If you have a triage room, well and good. If you don't have a triage room, if the big hospital, you might have an emergency room. If the small hospital, you will be having your labor room. From your labor room, you decide where the patient goes further. So how do you do that? Inform the family, companion or pregnant woman of the decision and take consent. Take consent at this stage, not after shifting her. Case sheets, the history, examination, investigation, and management should be completed. The ICU staff should be appropriately informed. We are now in COVID times. Just yesterday, when I was preparing, I prepared this slide yesterday. And when I was preparing this slide, there was a call from Chikbalapur, which is about 1 hour away from Bangalore. The patient had gone in for a gross pulmonary edema and she was not maintaining the saturation. They said, we would like to shift her. So I brought in 2 points. One is, will she tolerate 1 hour of shift when her saturations are not maintained? I would suggest that you stabilize her some more and then shift her. The second important problem that I had was the COVIDs are occupying quite a few beds in the ICU. So we are unable to procure beds for some of our patients who really require ICU. That has been happening. HDU, yes, but since a patient with pulmonary edema would definitely require ventilation, would definitely require an arterial line, would definitely require repeated ABGs, this is a patient I cannot manage in HDU. She has to go to ICU. Okay. So you should inform the staff, make sure the bed is ready, make sure the monitors are on, make sure the ventilator is available there. The patient should be escorted by a doctor, staff with all existing treatment, including continuation of patient IV line and oxygen. That's a picture which shows how a patient is being transferred in my hospital. You have a nurse, you have a doctor, you have a ward boy, you have IV fluid, you have blood going, you have oxygen going, and then the patient is shifted from the triage area to the ICU. Keep monitoring the vitals of the patient, at least 2 health workers to accompany, adequate follow-up by the treating doctor. Just because you have shifted the patient to your ICU or to another hospital's ICU doesn't mean you can wash your hands off. You have to follow up the patient. Make sure that you're giving her oxygen and supine hypotension is prevented. You can see that a trolley is kept a little up. That is to prevent the supine hypotension. Ensuring a patent airway, and baby should be shifted along with the mother if delivered already. Now this applies very well to the HDU. Otherwise, you have to shift the baby to NICU because you cannot shift a newborn to ICU since, as I told you, it's a zoo. Now, next we come to the transfer between hospitals. Now, even in my lifetime, I've seen this changes, what you see over there coming in. As a postgraduate, I've managed patients who were transferred to my teaching hospital in bullock cart. I've gone to a bullock cart and literally lifted a patient and brought her into the hospital. From there, we had, something like cycles and things helping the patient to modern day ambulances with all facilities. And now we are moving into an era of helicopter ambulances. So, but as long as you have an adequately skilled team and appropriate equipment, it should be okay. Of course, bullock cars and tricycles are now out between an ambulance and a helicopter. Now, how do you transfer between hospitals? Let's say my hospital doesn't have an ICU. Now my patient requires ICU. What do I do? First, we have to do a pre-transport evaluation of the woman and her fetus, and the maternal status must be stabilized before transport. Now, don't wait just to get rid of the patient. I've seen that happening many times. Just to get rid of the patient is transferred across. Let me give you a very nice example over here. This was a call to me from an anesthesiologist of another hospital, telling that my close friend he has given anesthesia to some of my patients. They're outside, not in my hospital. I said, Prakash, we are shifting this patient. I said, okay, tell me what happened. No, she had postpartum hemorrhage. We did hysterectomy. She had more bleeding. We have put in pack inside. Now we have closed it and she's all right. I said, what is the pulse rate? An anesthesiologist tells me the pulse rate is 84. Okay, so my antenna had already gone up. This kind of a patient, you cannot expect a pulse rate of 84. It's impossible. And I said, if you are sure that you want to shift it, if you're sure that she's alive, please shift her. I'll see her. Now, when she came, my doctor went to the ambulance to see the patient, and believe me, there was rigor mortis. So patient had died more than 1 hour before. Okay, so please don't, just to get rid of a patient. Otherwise, you are scared that the relatives will break your hospital. We should not do that. We should stabilize the patient and then transport her. Now, if maternal transport is unsafe or impossible, or when an imminent delivery is anticipated, arrangements can be made for postpartum rather than antepartum maternal transport. I know it's very difficult, but then we have no choice because it is better to deliver in your own small hospital than to deliver on the way in the ambulance. I've done that. I had to go to the ambulance halfway through and deliver the patient in the ambulance, and patient had PPH and I know everything, but fortunately she went home. Now, the necessary transport monitoring for a critically ill pregnant woman or a woman during the postpartum period includes continuous cardiac rhythm and pulse oximetry monitoring and regular assessment of vital signs. So there should be a trained person who's going with this patient in the ambulance doing all this check. Venous access must be established before transport. Now, let me tell you, even in the city of Bangalore, I've had patients with eclampsia who had thrown 3 convulsions, not given a single drug, nor coming in with an IV line in situ. The moment the first convulsion might have occurred at home, second convulsion as the patient is entering the hospital, third convulsion as the doctor is examining her, and they just want to get rid of her, shift. Please don't do that. If you have a patient like this, give magnesium sulfate. Put an IV line. If you're not sure what fluid to give, at least put an IV line. That will save a life. Left uterine displacement when she's pregnant should be routine during transport. Intubation and mechanical ventilation, if expected, should be accomplished before departure. Don't say, anyway, you're going to tertiary care hospital, you do an intubation there. No. The amount of hypoxia that's going to come in the 15 minutes, half an hour of transport is very important. And inform the obstetrician at the tertiary hospital, giving all details and whatever treatment you have given. Next slide, Parma. Okay. Now, what is our role in ICU? If, let's say, whether it's open or closed, either way, what will be our role? So when obstetric patients are transferred to the ICU, the obstetrician's role will depend on the patient's status, whether it's an antepartum patient or a postpartum patient. And the ICU model, whether they're open or whether it's closed. I told you my ICU is open, and every decision I take for the patient is directly my responsibility. Now, regardless whether it's a closed model, open model, you're the chief person, someone else is the chief person, patient care decisions must be made collaboratively between the critical care specialist, obstetrician, and the rest of the multidisciplinary team. So make sure that you have a dialogue with everybody and then take your decisions. I've again been very lucky because the nephrologists, the cardiologists are all my friends, and anytime anything is required, even at 2 a.m. in the night, I call them up and they're there for help. So that kind of a rapport you definitely need to build up with the multidisciplinary team. The decision should also involve the patient or her family or both. The risks and benefits of intervention such as medication, administration, and diagnostic image is directly your responsibility, whether it's open or a closed ICU. So you should know what medication we can administer and what imaging we can do. Now remember, women's interests are paramount. Optimizing the maternal condition will optimize the fetal condition, and medical intervention and diagnostic imaging may be modified to an extent, but do not hold any treatment or any investigation just because you have a doubt that the fetus may be affected. At this stage in life, we want mother to be safe. Then we also need to give recommendation regarding fetal monitoring and delivery planning, evaluation of the vaginal or surgical site bleeding, obstetric sources of infection, therapies such as magnesium for eclampsia and lactation. So there may be a surgical re-exploration of the abdomen is what we may have to do. So these are the situations where you will be directly involved, even if it's a closed ICU. Next slide, please. So now the patient has reached the ICU. How do you handle her further? What do you do further? Next slide, please. So now I'm repeating again, maternal stabilization is the first priority. Recognize, assess, and then stabilize. For cardiopulmonary resuscitation, we have to follow the CAB bundle approach, not the ABC. ABC is now out. C, the circulation is most important. So we follow the CAB bundle approach. This has come in, I think, from 2017. Anticipate difficult airway and endotracheal intubation. Because the woman is pregnant, there could be a laryngeal edema, and you need to intubate sometimes to prevent aspiration. Supplemental oxygen, depending on the oxygen saturation, your target SpO2 is 95%. If she's maintaining on room air, well and good. If not, give her oxygen, nasal prongs, still not working. Give her high frequency, still not working. Think of NIV, still not working. Think of ventilation. Judicious fluid administration to optimize preload to prevent overload. Do not overload these patients. These patients are very fluid sensitive. The left lateral tilt or lateral uterine displacement to avoid supine hypotension. Quite often we miss it. We need to be very careful about this particular aspect. Now, form a differential diagnosis, then determine the fetal gestational age because it is likely to affect the plan of care. And If the fetus is going to benefit, administer steroid at this stage. Now, pregnancy often modifies the drug effects and serum levels. Neither necessary medications nor diagnostic imaging, I already brought this point out, should be withheld from a pregnant patient because of fetal concerns. Mother takes the priority. Changes in fetal heart rate. Sometimes what happens, you feel the patient looks normal, but when you do a CTG, you find that the CTG is not normal. What does that tell you? Changes in the fetal heart rate monitoring should prompt reassessment of maternal BP, oxygenation, ventilation, acid-base balance, or cardiac output. Correction of these factors could result in the improvement of tracing and allow for further fetal and maternal resuscitation without delivery. So be careful. Either you can identify first the problem with the mother and then treat the fetus, or you may identify problem with the fetus and then go back to the mother. So once you have done all these, you get a provisional data based either on history and then your examination, and then finally the laboratory and radiology helps you out further. Next slide, please. Now, in the clinical monitoring, we have various things involved. The invasive BP monitoring or even a non-invasive BP monitoring, most of the time I just told you is fine. The arterial pressure waveform analysis, if you put in an arterial line, a central venous pressure catheter, pulmonary artery catheter, we'll see later that is not of much use now. Extravascular lung water has to be checked. Neurologically, check for the bispectral index, continuous EEG required, and intracranial pressure, depending on the symptoms. Pulse oximetry, we have all become experts thanks to COVID. We all know everything about pulse oximetry now. Then the jugular venous bulb oxygen saturation, clinical sedation monitoring, a gastric tonometry, then a capnography may be required to see the amount of carbon dioxide buildup. Look at the respiratory mechanics and POCUS. POCUS is point of care ultrasound. Now, POCUS has become a big thing since 2019. So many situations where we can use POCUS in our critical care patients. And of course, you must monitor the cardiac output. Next slide, please. Okay, so now we have got some data. Now we'll go, how do we prognosticate this patient? So for that, we have the scoring systems. Basically, we have two types of scoring systems. One are the general critical care scoring systems, that is the GCCSS. Now, they are the outcome prediction model, but they are not specific for pregnancy, mind you. So one of them is the Apache score. Apache is the acute physiology and chronic health evaluation score from 1 to 4. Or you could have SAPS, or the simplified acute physiology score. Then you have the organ dysfunction scores, which includes multiple organ dysfunction score, sequential organ failure assessment score, or the SOFA, and a quick sequential organ failure assessment score, which is called as the quick SOFA or the QSOFA. Then you have the obstetric prediction models that have now come from the last few years. They are either the MUOS, the Modified Early Obstetric Warning System, or you could have VIOS, that is the Obstetric Early Warning Score. Then you have the Obstetric Comorbidity Index Score and the Maternal Early Warning Score. At the same time, we have the decision-specific obstetric scoring system. We have the full Piers integrated estimation of risk model, or the full Piers model for preeclampsia. So if full Piers model, if you do on your preeclamptic patient, you get to know, okay, this patient has got good prognosis, this patient doesn't have a good prognosis. I have to be careful. The sepsis and obstetric score, or the SOS score, and finally, if it's an obstetric hemorrhage, do a shock index. Shock index is nothing but the ratio between heart rate and the systolic blood pressure. Next slide, please. So we'll just quickly go through the obstetrically modified quick SOFA score and the QSOFA score. Now, so most of these scorings are very cumbersome. You have to put a lot of factors together, do a lot of calculation to get the score. So now we have come out with two simple scores. One is called the QSOFA, and the other one is again QSOFA, but obstetrically modified QSOFA. Now, in QSOFA, you look at hypertension, the mental status, and the respiratory rate. Three major factors. So hypertension, less than 100. If there is an altered mental status, your patient is not responding well, or she's answering something, you're asking her something, and she's answering something, beware. Or if the respiratory rate is more than 22. Any score above 2. Now, this would hardly take you a few seconds to assess the patient. Any score above 2, greater risk of poor outcome. Now, a little more detail of this would be the obstetric modified QSOFA score. Next slide, please. Next, in critical care, we need to do hemodynamic monitoring. Now, how do we do the hemodynamic monitoring? The commonest one that we use is the CVP or the central line, for which the internal jugular is most preferred, but you could also use it subclavian. In pregnancy, we avoid using a femoral cath because the complications of thrombosis are much more if you use a femoral cath. So we use either a jugular or a subclavian axis. Okay, we can do an invasive arterial pressure monitoring with an arterial cannulation if we are doing. Now the central line is important because if you have to give vasopressors or if you have to give large quantity of fluid or blood, then peripheral lines are no good. You definitely need a central line in this patient. For example, again, to give you a simple example, for all my placenta acquisita syndrome patients, even before I put my knife, a central line will always be in place. So you need to, when I need a fluid, I can just rush in. Now, the arterial cannulation is indicated when instantaneous BP monitoring is needed. Now, this is not needed for a majority of our critical care patients, but those who are in deep shock, definitely arterial cannulation is worthwhile. And even if your patient is on double support or triple support, you need to do arterial cannulation. Even when you have to do a frequent ABG, for example, you have a patient with septic shock who's not very stable. Every 2 hours, you may have to do an ABG. I can't be pricking a radial artery every 2 hours. So an arterial line will give me the access that I require. And the most common artery that we use is the radial artery. Now, the pulmonary artery catheter or the Swan-Ganz catheter was widely used before in critical care medicine, but now has largely been replaced by minimally invasive monitoring. So far in I would say my entire life, I put a pulmonary catheter only for 2 cases. And one of them was an amniotic fluid embolism and one was a pulmonary embolism. We don't require now. From the last few years, I've not put even one pulmonary artery catheter. Okay, so you can do without it. Next slide. Now, next we come to the investigations that we need to do in a critical care setting. Why we need to do investigation? Because they help us to identify what is wrong with the patient, support, guidance to further treatment, and we can advise the family accordingly. Next slide, please. So what are the investigations we do in an ICU? Now, in Triage, then you do a monitoring, which could be a prognostic, a point of care test, or you could do a diagnostic test. There are certain common profiles that you have to do in these patients. They are the hematological profiles, the biochemical profile, the metabolic profile, microbiological profile, the radiological profile, and of course, to that now we add the infection profile. Now, all this will have to be done for all patients who are going into an ICU. Otherwise, in general, we also do an ABG, a ECG, a chest X-ray. I told you we need to do a POCUS or a point of care ultrasound. A GRBS is must. Please remember that we have got a condition called as acute fatty necrosis of liver, where you will find severe hypoglycemia. Or recently we had a patient who was referred to us in a state of shock, and when we checked the sugar, it was 460. Now this patient was in diabetic ketoacidosis. No one has bothered to check her sugar because 28-week GCT, whatever that done, was normal. And so they have not bothered to check her further, and she came as DKA. So echo is must. I'm sure Madam Pratima will also tell us when she's talking about preeclampsia, the importance of echocardiogram in preeclampsia, and of course in cardiomyopathy and in pulmonary edema and so on. Now, IVC collapsibility index is one where we can use to check the hydration. Again, it's a type of POCUS. Then we also need to do obstetric-specific investigations like non-stress test and bedside ultrasound for fetal evaluation. Biomarkers, like if I have a patient of preeclampsia, invariably I will do a bedside glycosylated fibronectin to see how the prognosis is. If the glycosylated fibronectin is more than 600, I know this patient is going to give me a lot of trouble and I need to deliver at the earliest. However, if it is less than 200, then I know I don't have to worry so much. And of course, we need to do a urine dipstick. Next slide, please. So what we follow in ICU is what is called as the I test tool. What is the I test? I is the condition reversible or irreversible. That is what you're trying to identify. I. T. If I do a test, will the test change the management and outcome of the patient? E. Is your physical examination conclusive or inconclusive? S are the clinical signs and symptoms. Are they typical or are they atypical? Now, let me tell you, it is not very easy to identify clinical signs symptoms in a critical care patient. I've had any number of jaundices for whom I have had to literally break my head that whether it is an infective hepatitis where I don't have to deliver her, or is it an acute fatty necrosis of liver or a hepatic dysfunction with HELLP syndrome where I have to deliver. And mind you, it's very easy to say, okay, we'll do this test, this test, this test. Please remember, at the night 2 a.m., even in the best of the hospitals, you will not get your infective hepatitis profile. If it's a Saturday night when most of our patients come, it will be available only on Monday afternoon. By the time your patient is either fine or dead. So you have to take those decisions, and it's very difficult. And finally, T is for analyzing the test result and treat using appropriate bundle of care. Now, for all critical care patients, starting from hemorrhage to preeclampsia to sepsis, we use what is called as bundle of care. There is a set of management protocols which are all done together. So you do eye test on them next. Next slide, please. ABG is very, very important, and we need to do the ABG for this patient. This is one picture to show how blood is being drawn from the radial artery for ABG. Once you do ABG, you have to analyze the oxygenation, assess the pH, assess for respiratory disturbance, and assess for metabolic disturbance. Based on all these findings, you interpret your result. Now, the normal value during pregnancy, mind you, is there is a little bit of alkalosis because of hyperventilation. So your pH is going to be between 7.4 to 7.46 in pregnancy, and the PO2 will be a little high, 101 to 106. Now we need to remember this every time we look at an ABG, because if you compare the ABG to a non-pregnant patient, you will not get your correct answers. Now look at this ABG which I've shown, the test ABG which I've shown there. You see that the pH is 6.97, lactate is 10.4, and anion gap is 22.2. That means this patient is in deep, deep, deep trouble. Next slide, please. Now, the next very important thing is trending. One set of investigations is never enough for a critical care patient. You have to trend them. Now, I've just shown a patient who was referred to me as severe preeclampsia with a massive ascites. What the fluid that you can see coming out in the third picture is not amniotic fluid, it is ascites, and I brought out 6 liters of ascites in this patient. So this is the kind of trending we did for that patient. Of all investigations, I've just shown you a few to just impress on the fact that single investigation is not enough. Next slide, please. Okay. Now the next, what most of the obstetricians and the relatives of the patient are worried about is the risk of fetal radiation exposure. Please remember that to have teratogenicity, you need an exposure of 50. Yes, thank you, Venugopal. I should be finishing in 5 minutes. 50 to 100 milligrays. For oncogenicity, you need 20 to 50 milligrays. Now, compared to that, if you take a chest X-ray with abdominal sheet, any X-ray patient in a pregnant patient, you have to shield them. And the exposure is only 0.01 mgy. That means I can take 1,000 chest X-rays without worrying about what's happening to the fetus. Similarly, if I have to do a perfusion ventilation ratio or a CT pulmonary angio or a CT pelvis and abdomen or a CT thorax for that matter, which we did in most of our COVID patients, the exposure is just borderline. Most of the time it is around 30 mgy, and you could take just a short burst of radiation so that you keep it even lower. So do not hesitate to do an X-ray if it is required. Next slide, please. Then, of course, the mechanical ventilation you have to do. Most of the time, the mechanical ventilation, the intensivist is going to help you out. But you should know that generally when we do a mechanical ventilation, a PaCO2 of 40 millimeters of mercury in a pregnant patient is concerning of progressive respiratory failure. So you need to ventilate them a little more faster. Next slide, please. Now, fluids is very, very important in a critical care setting. Do you keep her dry? Do you keep her wet? Or you have to be just right? So it's a very tough balancing act between hypovolemia and hypervolemia. And the picture below that you see is a volume overload showing an IVC collapsibility. You can see in the lower panel, the IVC is, you can see it's all bloated up like this. The black band going at the lower end of that picture, that means there is enough fluid in this patient. If this IVC had collapsed, then I know that I have to give more fluid to this patient. Now, most of the time, the obstetric patients are best managed with neutral or negative fluid balance, because even if an acute pre-renal failure comes in due to negative balance, it can be easily reversed. Whereas if you give her more fluid, she'll go in for pulmonary edema. Next slide, please. Yeah, you must know a little bit about syringes and infusion pumps. So the top one is the syringe pump, the bottom one is the infusion pump. It allows you to give fluids at specific rate, specific time, and specific volume. Next slide, please. A little bit about vasoactive drugs. I'll just take half a minute over here. There are two kinds of vasoactive drugs. One are called as the vasopressors, and the other one are called as the inotropes. Vasopressors means just like squeezing a lemon, you're squeezing the arterial tree to increase the blood pressure. They stimulate the smooth muscle contraction of the capillaries and arteries, causing vasoconstriction, resulting in rise in mean blood pressure. The commonest examples are noradrenaline and vasopressin. Inotropes are like pumping. Just as you pump a tube of a cycle, they increase the force of contraction of the myocardial muscle by causing a positive inotropism, and adrenaline and dopamine and dobutamine belong to this group. Whichever group you use, your ultimate aim is to improve tissue perfusion and oxygenation. Next slide, please. Now, apart from all this, you must look at DVT prophylaxis, either pneumatic compressors, or if you can give heparin to this patient, look after the nutrition, and if a surgery is required in this patient, do not hesitate. Go ahead and do the surgery. That could be life-saving. Next slide, please. Care of the fetus, of course, is very important. Use CTG whenever required. Labor and delivery as per maternal or fetal indication. Next slide, please. Now, role of resuscitative hysterotomy is very important. Most of the time, we are told that within 4 minutes it can be done. But from the last 2 years, we have got plenty of articles which say that even if you do it in 25 minutes, you have 50% chance of getting an injury-free survival rate of the baby. Now, remember, when we do resuscitative hysterotomy, we are not looking at the baby technically. We are looking at the mother. We want to improve the oxygenation of the mother. So 4 minutes rule is fine. If you can do it within 4 minutes to 5 minutes, nothing like that. But if you can't do, and you have already spent 10 or 15 minutes, do not hesitate. You have time till 25 minutes. You may still be able to help both the mother and the fetus. That was one very important point I wanted to bring out, because from last 2 years, many articles have come about it. Next slide, please. Now, medical legal problems are very important in a critical care setting. Your documentation and records are very, very important. Record sequence of events, sequence of time and administration of drugs, fluid, blood products, times of surgical intervention, and the condition of the mother. There are many ethical dilemmas in obstetric care. If you have a patient who is comatose, do you keep her alive just for the sake of the fetal maturity? Cases have been recorded like that. Personally, I had also kept the patient alive for 1 month just to deliver the baby. But then there are a lot of ethical dilemmas in it. The other ethical dilemma that you would have is for organ harvesting. Do I just keep a pregnant woman alive because we want to harvest the organ and save somebody else's lives? Now, there are a lot of newer questions that are coming up. Possibly we'll be involving our mind more and more with that. Next slide, please. Now, remember, training and drills are very important for our critical care. Otherwise, we'll be like this a football team where each one falls over another. But no, you should be like the symphony where everybody does what they are supposed to do. So training and drills are very, very important. Next slide, please. So the final message is critical illness may complicate any pregnancy. Consider the physiological changes due to pregnancy. Early warning scores can predict clinical deterioration. Blood gas analysis is often a very good tool to risk categorize a sick parturient. Obstetricians must be familiar with the issues pertaining to care of pregnant women with multiple organ failures. Many obstetric disorders may mimic medical disorders, so constitute a multidisciplinary team and be the linchpin to correct diagnosis even while resuscitative measures are on. The best hope for fetal survival is maternal survival. The team must decide whether the delivery will alter the natural history of the disease process and improve maternal survival. No effort should be spared in the management of critically ill pregnant women because the outcomes are often dramatically better than expected from the initial severity of the illness. Now, please remember, all of you are braver than you believe, smarter than you seem, and stronger than you think. So do not hesitate to manage critical care patients. Only make sure you have an eye for it and make sure you look after the patient well. Thank you very much.